The CML and MPN session is one where I expect we will be discussing a lot in the use of TKIs in CML. These have been established now for almost 15-20 years. We have 6 different TKIs approved in chronic myeloid leukemia. The survival for chronic myeloid leukemia in 1980 was less than 10% at 5 years. Today this is 96%, so a dramatic improvement in that survival from less than 10% to more than 90%. And a lot of this is because of the very powerful targeted TKIs towards BCR-ABL. So one of the big questions in the CML field now is emerging is which patients and how early can you actually stop therapy for a true cure? And I think this will be discussed quite a bit. There's a lot of data from both European and the United States cooperative groups showing that there are patients who have certain favorable features at baseline as well as favorable kinetics of response who may be able to stop all treatment at 3 to 5 years if they meet certain parameters. And this is something that is being done more and more in both academic and community settings. I think the other area of interest in CML is there a possibility to combine drugs with the current TKIs to get a deeper, earlier molecular and MRD clearance, which may then allow for earlier discontinuation or treatment-free remission. This is not something we have been able to show yet in CML, but a number of trials are looking at adding hypomethylating agents, JAK inhibitors, immune agents, and others to frontline treatment. In the myeloproliferative disease, I think the big theme now is how can we move beyond single agent JAK inhibitors for the treatment of primary myelofibrosis or secondary myelofibrosis. So we now have 4 different JAK inhibitors that have been approved: ruxolitinib, pacritinib, fedratinib, and momelotinib, and these work quite well, but we are not able to achieve a deep molecular eradication or complete cure, which then means patients have to stay on these medications for long periods of time, which may have side effects as well as cost. So there's a lot of efforts to try to add drugs to these frontline JAK inhibitors with hypomethylating agents, with the BET inhibitors, with BCL-XL or BCL-2 targeted therapies, and a number of these phase 3s are ongoing. The hope is this will lead to deeper, more durable, complete remissions, which will then allow us to maybe stop therapies after the initial 2 or 3 years, leading to long-term durable cures. We don't know this yet, but I think there's a lot of interest in that direction.